Therapeutic modalities are best understood as controlled clinical stressors. Heat, cold, electrical current, compression, water, or sound energy are only useful when the dose fits the tissue, the healing stage, and the patient's functional goal. By the end of this session, the priority is not memorizing a list of machines. The goal is to reason through why a modality is chosen, how it supports the plan of care, how safety is screened, and how legal duties, such as consent, scope of practice, documentation, and equipment safety, protect the patient and clinician. This first section builds the foundation: what a therapeutic modality is, why clinicians use modalities, and why they must remain connected to rehabilitation goals. A therapeutic modality is a purposeful stress applied to the body to trigger an involuntary physiological response. That response may involve temperature, circulation, pain modulation, neuromuscular activation, or tissue extensibility. The key word is therapeutic. The stress must help the current tissue problem, rather than simply create sensation. The same modality can be helpful in one stage and inappropriate in another. For example, aggressive heating over highly irritable acute swelling may increase symptoms, while heat before mobility work may help a chronic stiffness presentation. Dose and timing should be reasoned like an exercise prescription. Modalities deliver energy or mechanical load to tissues. Thermal energy changes tissue temperature, electrical energy influences nerves or muscle, mechanical force may affect fluid movement or mobility, and hydrostatic forces use water pressure and buoyancy. The body then responds physiologically. Clinically, the response depends on dose, depth, tissue type, healing stage, contraindications, and patient factors such as sensation or circulation. A modality is not automatically beneficial because it is familiar. It becomes useful when the chosen input produces the response needed for the next rehabilitation task. Modalities are commonly used to make active care possible. If pain, guarding, swelling, or stiffness prevents good movement, a modality may lower that barrier long enough for exercise, mobility work, gait training, or functional progression. Some modalities also create direct physiological effects, such as altering circulation, tissue extensibility, neuromuscular activation, or pain signaling. These effects support the healing environment, but they do not replace tissue repair or loading progression. Pain control is valuable when it improves participation and confidence without creating dependence on passive treatment. A modality should lead to an active next step. Pain-limited range of motion may benefit from symptom reduction, but the follow-through is mobility work and graded loading. Muscle inhibition may be assisted by stimulation or other facilitation strategies, but strength and motor control still must be retrained. Stiffness may respond to warming or other extensibility strategies, but gains are preserved through movement and load tolerance. In acute presentations, symptom modulation may be appropriate, while protection, education, and progression criteria guide activity. Passive-only care risks temporary relief without solving the performance deficit. Clinical reasoning connects the evaluation to goals, treatment selection, and re-evaluation. This section emphasizes a repeatable process rather than modality selection by habit. The plan of care loop begins by recognizing the patient's problem, then prioritizing which problem matters most today. Goals translate that priority into a measurable target. Evidence and clinical experience help narrow treatment options, and the treatment plan identifies the modality, parameters, active follow-through, and monitoring strategy. Re-evaluation closes the loop. If the response does not match the goal, the clinician should reconsider the problem list, the goal, the evidence being applied, or the selected intervention. This prevents routine modality use without a clinical purpose. A plan of care starts with the evaluation and working diagnosis, but it must be individualized. The clinician identifies impairments, activity limitations, sport or job demands, available resources, and patient preferences, then turns them into short-term and long-term goals. Progression should be criteria-based rather than simply time-based. Tissue healing and irritability set boundaries. Goal completion tells us whether the next step is appropriate. Performance quality shows whether function is improving, and reevaluation identifies when to progress, regress, or change the intervention. If a modality does not advance the goal, it should be reconsidered. SMART goals make modality decisions defensible. Specific means the goal names the activity or behavior. Measurable means progress can be observed or counted. Achievable keeps the target realistic for the patient and setting. Relevant connects the goal to what matters to the patient, and time-specific gives a target date or phase. Goal attainment scaling adds a structured way to judge whether the outcome is expected, better than expected, or less than expected. This matters because modalities should be continued only when they help move the patient toward the agreed outcome, not because they were used previously. Treatment goals guide which modality, if any, is appropriate. A pain goal may require a different input than a mobility, tissue function, or flexibility goal. Patient factors also influence the decision. Sensation, circulation, skin integrity, irritability, medical history, preferences, and prior response can all change the safest choice. The clinical question is which controllable input best supports today's goal without violating indications, contraindications, precautions, or stage of healing principles. If no modality improves the plan, active care may be the better choice. Before choosing a modality, screen both purpose and safety. Indications ask whether the modality fits the condition. Contraindications ask whether it should not be used for this patient or body region. The desired physiological effect should be named clearly, such as pain modulation, tissue extensibility, edema control, activation, or circulation change. Injury stage matters because acute, subacute, and chronic tissues tolerate stress differently. Patient preference and previous response affect adherence and safety, but they do not override contraindications. Equipment availability, prescription parameters, and alignment with the plan of care complete the decision. Progression requires monitoring both the goal and the tissue response. A treatment should be challenging enough to promote adaptation, but not so aggressive that it exceeds tissue capacity or worsens irritability. If the patient meets the goal with acceptable symptoms and movement quality, parameters or activity may progress. If symptoms increase, technique deteriorates, or the expected response does not occur, the clinician should modify the dose, change the modality, adjust the goal, or reevaluate the diagnosis. Monitoring protects the patient and keeps the plan responsive instead of automatic. Safe modality use also requires legal and professional reasoning. Consent, scope of practice, documentation, facility safety, and equipment oversight are part of clinical care, not separate paperwork tasks. Scope of practice defines what the clinician is legally and professionally allowed to do based on credential, state law, employer policy, and setting. Standard of care asks whether the clinician acted as a reasonably prudent professional with similar training would act in similar circumstances. Informed consent is the patient's understanding and agreement after hearing the modality, procedure, expected benefits, normal and adverse sensations, hazards, and residual effects. With minors, guardian permission may be required, and the minor's assent still matters. Unwanted treatment can raise a battery concern, even when the clinician intended to help. Negligence is analyzed through 4 linked elements. Duty of care means a clinician or organization had a responsibility to act. Breach means the action or inaction fell below the applicable standard of care. Damages mean the patient experienced legally recognized harm, such as injury, cost, or loss. Proximate cause connects the breach directly to the harm. In modality care, defensible practice includes screening, rational parameter selection, safe setup, monitoring, reevaluation, and clear documentation. Good documentation does not make unsafe care safe, but it helps show that care was deliberate and reasonable. Problematic conduct can occur by failing to act or by acting unsafely. Nonfeasance is an omission, such as ignoring a patient who reports burning, dizziness, or worsening symptoms during a treatment. Misfeasance is an unreasonable action within a general role, such as using a modality without adequate screening or with parameters beyond training. Malfeasance is a wrongful or unlawful act, such as deliberately violating licensure rules, policy, or safety requirements. The clinical bottom line is balanced responsibility. Do not abandon the patient when action is required, and do not provide care that is unsafe, unauthorized, or unsupported. Risk management begins with a safe facility, written policies, and an organized treatment area. Regulatory awareness includes federal and state requirements, FDA expectations for medical devices, OSHA safety considerations, and licensing board rules. Professional ethics require practicing within training, using evidence-informed decisions, and respecting professional codes. Equipment oversight means following manufacturer instructions, maintaining calibration and inspection records, and removing unsafe devices from service. Documentation should capture screening, consent, parameters, patient response, reevaluation, adverse events, and follow-up. The record should make the clinical reasoning understandable after the visit is over.
Facility safety should be addressed before the patient is positioned. Electrical equipment used near water requires appropriate safeguards, such as ground fault circuit interrupters, and hydrotherapy areas need attention to water, electricity, temperature, infection control, and slip hazards. Treatment areas should allow safe traffic flow and access for monitoring. Equipment must be maintained according to manufacturer instructions and facility policy, with inspections and calibration documented at least as often as policy requires. FDA device resources can help clinicians understand safety reporting and medical device expectations. Damaged, unsafe, uncalibrated, or out-of-policy equipment should not be used. Informed consent is a communication process. The patient should know who is treating them, what modality is being used, what the procedure involves, and why it fits the current goal. Normal sensations should be distinguished from adverse sensations. For example, warmth, pressure, tingling, or muscle contraction may be expected for certain modalities, while burning, sharp pain, numbness, dizziness, or unusual discomfort may require stopping. The patient should also understand potential hazards and residual effects after treatment. Consent should be revisited when parameters, risks, or patient responses change. Reliable application begins with positioning. The patient should be comfortable, supported, and draped or exposed in a way that maintains dignity while allowing correct placement and monitoring. The clinician must avoid contraindicated sites and unsafe tissue presentations. Preparation may include cleaning the skin, because lotions, sweat, or debris can interfere with electrodes or ultrasound transmission. Equipment knowledge matters before treatment begins. Parameters, accessories, and safety checks should not be improvised after the patient is ready. Some treatments require direct monitoring, and patients should not be left to change settings or control the device. Ending treatment safely is part of the intervention. Output or intensity should return to zero before disconnecting, so the patient is not exposed to an unexpected stimulus. Accessories, electrodes, towels, or equipment should be removed without unnecessary tissue stress. The device and treatment area should be powered down and cleaned according to policy. Reevaluation then determines whether symptoms, skin response, tissue status, function, or the goal-related measure changed as expected. Documentation should include parameters, location, duration, patient response, adverse events, and plan changes. Unexpected responses require stopping, reassessing, documenting, and escalating when indicated. The final section brings the clinical and legal pieces together into a practical decision process for safe modality use. A safe modality decision starts with the patient problem. What symptom, impairment, or activity limitation is blocking progress? The next step is a measurable goal, because treatment choice should serve that goal. Safety screening then checks contraindications, precautions, consent, and facility issues. The clinician chooses the modality by matching the desired energy or stress, dose, and setup to the target response. During application, response is monitored rather than assumed. Reevaluation determines whether the intervention helped and whether to progress, modify, or discontinue. This framework keeps modalities tied to outcomes. In this ankle example, the concern is not simply that the athlete has pain. The limiting problem is pain and stiffness that prevent quality balance work. The immediate goal is improved dorsiflexion enough to perform controlled balance tasks today. Safety screening should include healing stage, swelling irritability, sensation, skin integrity, circulation, contraindications, and consent. The selected modality should match that short-term goal and be followed by active mobility or balance work. The dose should be justified by the desired response and patient tolerance. Reassessment might include dorsiflexion range, pain during movement, balance quality, or ability to complete the planned task. Documentation should record parameters and response.
The main takeaway is that modalities are controlled stressors, not routine add-ons. They are therapeutic only when the stimulus fits the tissue status, healing stage, patient presentation, and current goal. The plan of care should move from evaluation to prioritization, goal setting, evidence-informed treatment, and reevaluation. Safe care also requires patient education, consent, correct positioning, monitoring, and documentation. Legal risk is reduced when clinicians stay within scope, meet the standard of care, maintain safe facilities, and can show clear reasoning. If new information makes the treatment unsafe or unhelpful, the modality should be stopped, modified, or avoided. These references support continued study of therapeutic modalities, evidence-informed electrophysical agents, athletic training ethics, medical device safety, and workplace safety expectations.